Welcome to the presentation on breast reconstruction created by Dr. Christopher Williams and Dr. Jeremy Williams at Park Meadows Cosmetic Surgery. This presentation is meant to be an educational tool to help stimulate questions and to inform patients about their breast reconstruction options. The goals of breast reconstruction are to restore a sense of self, well-being, sensuality, and femininity that is often an issue with breast cancer patients. Plastic surgeons are as much psychiatrists as we are surgeons in trying to restore a sense of balance to patients in a very difficult time. We continually seek improvement in cosmetic results and symmetry for breast reconstruction patients. With the increasing availability of state-of-the-art techniques for patients with breast reconstruction needs, we believe we can provide more natural and longer-lasting reconstructions while easing the recovery process. Strategies that use parts of the woman's body for breast reconstruction can be performed in less invasive manners and reduce the damage to underlying muscles and nerves. Plastic surgeons continually strive to improve the reliability of the reconstructions. Breast reconstruction has naturally evolved over the last 40 years, from the utilization of implants to the use of a woman's own tissue to reconstruct the breast. Use of a woman's own tissue to reconstruct the breast initially included taking large portions of the underlying muscles. In the mid-1990s, further understanding of the microvascular anatomy resulted in the plastic surgeon's ability to remove blood vessels with fat and skin still attached, without damaging or removing underlying muscle. These are called perforated flaps and are essentially muscle-sparing techniques that help protect the donor side of the patient. The flaps are specific to this type of breast reconstruction and are the deep flap, the S-gap, and tug flap. And there are others which are even more specialized. High-volume centers like the breast center at Park Meadows Cosmetic Surgery have been shown to have improved outcomes. Who is a good candidate for breast reconstruction? Any age of patient is possible, depending on your overall health, and each patient will be independently assessed. Poor candidates for breast reconstruction are those patients with significant heart or lung disease, patients with multiple significant medical problems, and heavy smokers. The presence of surgical scars on the abdomen does not exclude the abdomen as a donor site. There are 3 schemes for timing your breast reconstruction that will be determined by your surgeon. One technique is immediate reconstruction, which is performed or started the same day as the mastectomy. This means the patient wakes up with the beginning of her breast reconstruction already performed after her mastectomy. Another technique is termed immediate delayed surgery, in which a place saver or tissue expander is placed in the mastectomy defect to save the place and then to finish the reconstruction at a later date. This can be used for patients who receive or may receive radiation therapy in the future. This technique involves using a tissue expander placed immediately at the time of the mastectomy to preserve the breast skin. The final technique for breast reconstruction is delayed surgery. These patients may have had their mastectomy 1 year, 5 years, or even 20 years prior to the time that they come to the plastic surgery office. In other words, a breast or mastectomy defect can be reconstructed at any time. This usually occurs in patients who have had advanced disease or did not know their surgical options at the time of their mastectomy. In summary, options for breast reconstruction include tissue expander and implants, muscle-based flaps such as tram and latissimus flaps, and muscle-sparing perforator flaps such as deep, SIEA, tug, and S-gap flaps. A tissue expander is essentially a place saver. It is a deflated implant that is then inflated over time. A tissue expander can be placed immediately after a mastectomy, the same day as your surgery. The tissue expander is partially filled during the surgery, and each expander takes approximately 60 to 70 minutes to place. There are usually 2 drains placed and 1 pain pump per side. The skin is sutured with buried and dissolvable sutures, so the patient does not need to worry about knot or suture removal. Here is a diagram and artistic rendition of a tissue expander. The first picture on the left shows a delayed reconstruction with a woman with an old mastectomy. The middle picture shows the pectoralis muscle over the chest wall on the ribs. This is followed by a placement of a slightly inflated tissue expander, followed by a fully inflated tissue expander with the final reconstruction. The last photo reveals a patient with a breast mound after full expansion. At the breast center at Park Meadows Cosmetic Surgery, we use an acellular dermal matrix for all of our breast cancer patients who choose implant-based strategies. The use of this acellular dermal matrix allows a more rapid expansion, and many surgeons believe that this provides a more aesthetic breast contour. Tissue expansion patients can expect a post-operative course that consists of usually a 23-hour stay in the hospital. During subsequent visits to our office, the patient can be expanded through the skin with a small needle and some saline that is placed in the tissue expander. Once the expander has reached its full expansion volume, the expander is left dormant for about 2 months to allow the skin to rest. Stage 2 of the tissue expansion reconstruction includes removing the temporary tissue expander and placing the final saline or silicone implant approximately 3 months after the original surgery. If chemotherapy or radiation therapy comes first, then the tissue expander is removed after all treatments have been performed. The final stage of breast reconstruction using a breast implant is often the nipple reconstruction, which can be performed under straight local anesthesia. It can also be performed with a combination of other nips and tucks, fat grafting, and contouring to help improve the shape of the breast. The nipple tattoo or coloration around the nipple can be performed 3 to 4 months later for color matching. There are risks and complications for implant reconstructions, specifically skin healing problems that can be directly related to the mastectomy and can lead to delayed healing and infection. Infection is one of the most common complications of implant-based reconstruction and can require the total removal of the implant, return to the operating room to wash out and replace the implant, or IV antibiotic therapy for several weeks. Implant extrusion or loss of the implant through the incision is rare but can happen, especially in radiated patients. Capsular scar contracture is the scar tissue surrounding the artificial implant. Usually, the scar tissue is soft and supple and causes no problems, but in some patients, it can become quite firm and aggressive, causing pain and distortion of the breast. Visible rippling of the implant can be a concern for some patients with implant-based reconstruction. Breast asymmetry is common even in the preoperative state. We like to say breasts are sisters, not twins. Our goal is to make them look alike, but they may not be identical. Chronic pain or discomfort is rare in the post-mastectomy setting, but can be caused by the mastectomy itself, cut nerves in the chest wall, or capsular contracture causing tightness of the chest. The following are patient examples of implant-based reconstructions. The left photograph is always a photo of the patient preoperatively before any surgery. The right photograph always represents the patient after all surgeries are completed. This is a patient who has completed tissue expansion, silicone implant placement, nipple reconstruction, and areola pigmentation. This patient also had bilateral mastectomies. Her final product on the right shows a natural contour of the breast that can be achieved using implants. Her nipples have been reconstructed and the areolas have been tattooed. Understanding that every patient is different, this is a patient who demonstrates another variation of breast size and body shape. This patient has completed tissue expansion, implant placement, nipple reconstruction, and areola pigmentation. It is important to know that you will be a work in progress during your stages of reconstruction. This is an example of a patient without areola tattoos at the time of the photos. She has completed tissue expansion, implant placement, and nipple reconstruction, but has not yet had her areolas tattooed. Some patients with smaller breasts would like to be bigger after mastectomy and reconstruction. This is an example of a patient who is able to achieve a larger breast size through tissue expansion and has completed implant placement and nipple reconstruction. Another example of a bilateral mastectomy, placement of tissue expander and final silicone implants. This patient did not require or desire fat grafting for softening of the breast shape or implants. In select patients, a different technique can be used which skips tissue expansion and accomplishes breast reconstruction in a single stage. The final implant is placed immediately at the time of the mastectomy. This newer technique is particularly useful in women with smaller breasts. This patient desired a single-stage reconstruction. She also elected to have a nipple-sparing mastectomy. The picture on the left is pre-op. The picture on the right is postoperative, single-stage breast reconstruction. This completes our discussion of implant-based reconstruction. There are other strategies used to reconstruct a breast using a woman's own tissues. These are called autologous tissue strategies. Autologous meaning they come from you, tissue meaning they are composed of fat, skin, and sometimes muscle. An older technique that is still used today is called the tram flap. This flap utilizes the tummy tuck skin and the fat of the abdomen to reconstruct a breast, but it does sacrifice the muscle on the side from which the tissue is taken. This robs the abdominal wall of one or two very important muscles. The latissimus muscle is a large muscle in the back. This muscle and some of the overlying skin is removed and tunneled across underneath the skin to the front of the chest. An implant is typically used with this strategy to provide extra volume for the breast. Muscle-sparing techniques are often called perforator flaps. A perforator is a blood vessel that courses through or perforates through a muscle. That blood vessel then feeds the fat and skin overlying the muscle. Plastic surgeons across the world have named these perforators over time. This simple line drawing shows a schematic of a muscle fiber being split and the blood vessel being dissected out. It is still attached to the overlying fat and skin. It has a secondary advantage in some patients in that it does tighten the skin at the end of the procedure, providing a tummy tuck. However, it is important to note this is not a tummy tuck operation, but is truly a breast reconstruction with a cosmetic side effect in many patients. The scar, even though higher than a true cosmetic tummy tuck, is usually hidden by pence. The surgery can take 3 to 4 hours per side, an average of about 6 to 8 hours for a bilateral reconstruction. The operating microscope is used to reconnect blood vessels during the case. Because there is minimal loss of abdominal muscle function, there is minimal risk of abdominal hernia formation. You will notice that there is a blood vessel on the leftmost drawing in the groin. This is the deep inferior epigastric artery blood vessel. It courses through the pelvis, through the abdominal wall muscle, and into the skin. The blood vessel in the chest is called the internal mammary artery. The artery and its veins are often used for reconstruction. The middle picture shows the flap being removed with the blood vessel intact and the muscle still present in the abdomen. The final slide shows the reconstructed breast in the closed donor site. We often obtain a CT scan preoperatively to help identify where perforators are located in the abdomen. This saves significant time in the operating room. In layman's terms, this could be the stud finder when looking for a pipe behind a wall. If you consider the blood vessels to be a pipe which carries blood, this is a good analogy. This is an intraoperative rendering of the flap flipped over, demonstrating the perforator which courses through the muscle and down into the pelvis. The flap itself is removed totally from the body and is called a free flap. Free flap means that it is off the body, free in space, and needs to be reconnected. This is a schematic of how we reconnect the vein. We often use a venous coupler device which helps keep the vein open. It looks like a donut with spikes on it. It speeds surgery and has been incredibly reliable to provide adequate connection of the veins. In many of our patients, we elect to utilize immediate delayed deep flap reconstruction. This is a staged approach. A tissue expander is placed initially at the time of mastectomy as a space saver to allow final pathology to be reviewed and to determine the need for chemotherapy and radiation therapy. It is our desire to avoid radiation to the flap whenever possible. This method allows patients to address their cancer first while leaving reconstructive options available. In our experience, many of our immediate delayed patients have improved aesthetic outcomes, particularly in difficult to reconstruct breasts. Because many of our patients travel to our office from throughout the Rocky Mountain region, the immediate delayed technique allows surgeons from outside our immediate area to place a tissue expander at the time of mastectomy and refer the patient for final reconstruction using deep flap. The process of immediate delayed deep flap reconstruction entails placement of the tissue expander at the time of mastectomy, completion of chemotherapy and radiation therapy, subsequent removal of the tissue expander and simultaneous deep flap reconstruction, final shaping, nipple, and areola reconstruction. This is a patient who demonstrates each of the stages of immediate delayed reconstruction. Picture number 1 shows preoperative markings before mastectomy. Picture number 2 is after placement of tissue expanders and the completion of chemotherapy and radiation therapy. Picture number 3 is immediately after removal of tissue expanders and simultaneous deep flap reconstruction. Picture number 4 is after nipple reconstruction and areola pigmentation. Frequently in our practice, patients are referred from outside our immediate area and from throughout the Rocky Mountain region, having already undergone mastectomy and tissue expander placement in their hometown. Patients are often referred to us for immediate delayed deep flap reconstruction. In picture number 1, this patient had a tissue expander placed by a surgeon outside our immediate area. Picture number 2 shows the result after removal of right breast tissue expander and simultaneous left mastectomy and bilateral deep flaps. Picture number 3 shows the final result. Typically, deep flap reconstruction takes 6 to 8 hours in the operating room for a bilateral reconstruction. The patient then goes to the recovery room for approximately 45 minutes to an hour, and then is transferred to a regular patient floor. The blood supply of blood vessels are usually well established at 12 hours and is monitored with a special probe that transmits directly to your surgeon's phone. If there is a problem noted with the flap, you might return to the operating room. This is rare but can happen. The first night is your night of rest. On postoperative day 1, we will get you out of bed walking. Often physical therapy is consulted. You are allowed to eat. On postoperative day 2, you are walking more and many patients will go home this day. As you continue to recover, the postoperative course continues. Typically, patients start driving at 3 weeks. You can wear any bra at approximately 3 weeks. We would expect you to start moderate exercise at 4 weeks, and most patients are able to return to work in 4 weeks. Stage 2 in deep flap reconstruction is secondary shaping. The secondary shaping is performed 2 to 3 months later if the patient is not receiving chemotherapy or radiation. The opposite breast, if it was not addressed with a mastectomy, is also shaped to match the reconstructed breast. It is important to remember that these secondary shaping procedures are usually outpatient procedures, that the patient is discharged home that same day. These surgeries typically last anywhere from an hour to 3 or 4 hours, depending on the amount of work that needs to be done. Nipple reconstruction can also be performed at this time, depending on the patient. Pigmentation or tattooing of the nipple is typically done 3 months after the final shaping procedure. The average patient will actually get 2 to 3 operations before she is done with her reconstruction. It is important to recognize that all surgery carries some risk. Deep flap has its own specific set of risks. The reconnecting of blood vessels can fail. This leads to total loss of the flap, where that flap is no longer viable and has to be removed. Another strategy to reconstruct the breast will be discussed with your surgeon on a case-by-case basis. The national average for flap loss is approximately 3 to 4%. The actual flap failure rate for the breast center at Park Meadows Cosmetic Surgery is well below the national average. Occasionally, a patient will return to the OR to evaluate the flap or another problem. The national average for return to the OR is somewhere between 5 to 8%. The return to the OR rate at the breast center at Park Meadows Cosmetic Surgery is much less than the national average. Fat necrosis can occur. This is when a small area of the flap becomes firm. Typically, this does not form a problem. It is certainly not dangerous, and Doctors Williams and Williams strive to remove this fat necrosis through varying techniques. Hernia formation for deep flap is less than 1%. And though we strive to achieve symmetry, minor asymmetries can occur and should be recognized as normal. Infection and additional scarring along the abdomen can occur. The next series of slides will show pre- and postoperative photos for a variety of patients, all of whom have had perforator flap reconstruction. Again, the left photograph is preoperative before any surgery, and the right photograph is after all surgeries are completed. This first slide shows a woman before her surgery and after a left mastectomy. Her left breast was reconstructed using deep flap. Her right breast was not touched. The abdominal scar is hidden under the pants. Her nipple and areola on the left were subsequently reconstructed and tattooed. The next patient is an example of a bilateral mastectomy. Both breasts were removed, and on the same day her abdominal tissue was used to reconstruct both breasts. She underwent subsequent shaping procedures, fat grafting, and lifting of the breasts, followed by a nipple reconstruction and ultimately pigmentation of the areola. There are a very small number of women who qualify for nipple-sparing mastectomies. The important thing to remember for nipple-sparing mastectomies is that the nipples are always numb. The nipples themselves can also have wound-healing difficulties or irregularities that require removal of the nipple. Nipple-sparing mastectomies must be selected on a case-by-case basis. This is one example of a bilateral nipple-sparing deep flap. This woman has small breasts in the preoperative setting and a small but adequate abdomen. This patient also underwent bilateral immediate deep flap reconstruction. She is extremely thin, but we were able to augment and shape the breast with fat grafting by performing liposuction in the flanks, the hips, and the thighs. This fat is then used and injected into the flaps to soften contours and increase volume if needed. This is a patient who has a lifelong reconstruction. This patient had silicone implants utilized for reconstruction approximately 10 years ago. Her right implant is painful and ruptured. The patient desired to have her implants removed and replaced with her own tissue. The right picture shows her final result. The nipples are reconstructed and areola tattooed. Her pain in the right breast is totally gone, and she is extremely pleased with the change from her implants to autologous tissue. This is an example of a single-sided or unilateral delayed deep flap. The preoperative photo shows a woman with a mastectomy defect. Over 70% of women in the United States get no reconstruction after mastectomy. She had her mastectomy in her late 20s during a pregnancy. In her mid-30s, she now opted for reconstruction. The breast has been reconstructed with a unilateral or single-sided deep flap. The normal breast has been lifted and reshaped for symmetry. The nipple was reconstructed and the left areola was tattooed. In some instances, patients who desire more volume than their abdominal tissue can provide can have implants placed beneath their deep flap to essentially provide an augmentation. This patient has a small amount of abdominal tissue but desires to maintain her current breast volume. The picture on the right shows the patient after deep flap and implant placement beneath her flaps for additional volume. This patient has not yet undergone nipple reconstruction and areola pigmentation. Different strategies for reconstruction can be used in the same patient. This patient has had a latissimus flap on one side and a deep flap on the other. The latissimus flap is on the patient's right and the deep is on the patient's left. The donor site scar for the latissimus flap is seen in the right photograph and demonstrates how the scar is concealed. Some patients are not candidates for deep flap reconstruction or their abdominal donor site is not adequate. Other perforator flaps include SGAP, or superior gluteal artery flap reconstruction. While this is an option, it is a much more difficult one and usually one side is performed at a time. SGAP reconstruction is more difficult and has a higher failure rate. The gluteal donor site or bottom donor site is well hidden. It is usually sufficient for tissue reconstruction even in thin patients. Many patients consider this to be a faster recovery than deep flap. There is no risk of abdominal complications, and the thicker tissue from the bottom does provide good projection. There are significant disadvantages of SGAP reconstruction. These include a much longer operative time because of the challenging anatomy. It is much more technically demanding. Successful operations occur 93 to 95% of the time, which is less than the deep flap reconstruction, and it is not widely available. The postoperative course for SGAP reconstruction includes 1 night in an intensive care unit for monitoring, out-of-bed walking the next day, discharge from the hospital in 2 to 3 days. A compression girdle or garment for the buttocks donor site after the drain is removed in approximately 1 to 3 weeks. The patient may drive in 3 weeks and resume light exercise in 4 weeks and return to work at 3 to 4 weeks. SGAP reconstruction is also a staged reconstruction with secondary shaping procedures. Stage 2 is usually performed 2 to 3 months later. Again, skin procedures, fat grafting, shaping procedures can be performed as well as nipple reconstruction. The donor site can often have a contour irregularity from the removal of the fat. Therefore, liposuction is often performed in the buttocks region or the flank region to help disguise the donor site. Notice the drawing of the flap on the buttocks and the elevation of the flap in the right photo. This flap is then used to reconstruct the breast. The muscle is left in place. This is a patient that had a mixed strategy. Her right breast has been reconstructed with an S-gap from her bottom, and her left breast has been reconstructed by a deep flap from her abdomen. Sometimes this is necessary for thin patients. More and more women are electing to preserve their nipples at the time of mastectomy. This decision is usually made in consultation with a surgical oncologist and a plastic surgeon. The best candidates for this procedure tend to be smaller-breasted women with little drooping of their breasts and small tumors away from the nipple. It is important to remember that though the nipple is spared, it is almost always numb. Nipple-sparing mastectomies can be reconstructed using implants or autologous tissue. The top two pictures demonstrate a patient with implant-based reconstruction. The bottom two pictures demonstrate a patient with autologous reconstruction. We look forward to meeting you in your consultation with either Dr. Jeremy Williams or Dr. Christopher Williams at the Breast Center at Park Meadows Cosmetic Surgery. We are dedicated to breast cancer reconstruction and the care of breast cancer patients. Thank you for your attention. We know this will stimulate some questions, so write them down and ask Dr. Jeremy Williams or Dr. Christopher Williams at your consultation.